Good morning. Thank you, Professor Berge and the organizing committee for the invitation. I think it is very appropriate in that session, but at the same time, when I hear what was said this morning and when you will hear what we do, I feel very, it's extremely primitive approach, and I feel like an elephant in a China shop. So I don't know if I did that well. I think it reflects that I'm older than what you think I am. So I have to introduce the talk. I have used that slide, which is a very brief summary of our experience that was published 2 years ago of anatomical correction. In these 32 patients, there are only 21 double switch, and only 10 of these 21 have had a retraining. But on the other hand, the mortality and morbidity that are summarized in this paper shows you what kind of problems you can encounter in double switches, and that training of the left ventricle is not the only issue. So I think we have to talk about the other issues, and I will address them, all of them. So the retraining of the morphological left ventricle, you have to understand that this is a historical approach that was initiated simultaneously in Japan by Imai and by Roger Mee in Melbourne, and amongst the very few teams in the world that are dealing regularly with this patient. The influence of Melbourne and Roger Mee and the way to train has been very important. And so the original protocol to train the left ventricle in a patient with corrected transposition and intact ventricular septum or very restrictive VSD was to use on a patient that was fully loaded with quite high dose dobutamine, tighten the band to almost occlusion of the pulmonary artery so that you can test the maximum pressure that can be developed by the left ventricle in an untrained left ventricle, and then progressively relax the banding to achieve a pressure systemic, about 70% of the systemic pressure. So this very rough and brutal approach has been the one in Melbourne for many years until I arrived, and it also been adopted by Bill Brown in Birmingham, who worked with Roger Mee for many years, and you will see that the team in Boston uses the same approach, or roughly the same approach. Stanford is a bit more delicate, but this is a lot of what is associated with training of the left ventricle, the maximum age at which you can train, and the left ventricular dysfunction may be associated with the way the ventricle is actually trained in these teams. So this is a pressure volume loop of an actual morphological left ventricle being retrained, and that was done in Birmingham with the team of Andrew Reddington, and you can see a progressive increase in the left ventricular pressure. I would like to have it played again, but won't play. So you can see an increase in the left ventricular pressure and reach a peak, and then there is a decrease in the left ventricular pressure. So you have two setup of contractility. You are working along the intrinsic contractility of the left ventricle, and then you go beyond the point where you see a decline in contractility and decline in function, and severe step up in the end diastolic pressure. So the rationale is to go beyond that point and then deband slightly and leave the band at that level. That usually allows to reach a left ventricular pressure between 60 and 80% of the systemic ventricular pressure, So it is sometimes efficient to band the left ventricle at a very high level immediately, but on the other hand, these measurements are done in the operating room and quite acutely, and you cannot predict how the left ventricle will respond 2 days, 3 days, 1 week, 1 month after the band. And I am convinced, and there are also experimental data that shows that this aggressive method is a bit deleterious. So this is the Melbourne and Cleveland clinic. Roger left Melbourne in 1993 and then went to the Cleveland clinic where he carried on. Here, this is the D transposition who had an atrial switch and rebanding towards an anatomical correction, so an arterial switch. So you see that there are 39 patients, but only 35 have had a pulmonary artery band. And out of the 35 pulmonary artery band, you have 16 patients doing well. So less than half of them are doing well. So you have transplantation, early days, late death, and the doing well, you don't know exactly what are their ventricular function. But the conclusion, and it is the same conclusion from all these teams, is that beyond a certain age, you shouldn't train. In Birmingham, you have a group, when this paper was published in 2008, you had 11 patients who had retraining and a double switch operation, but you had 6 patients who did not have a double switch. 1 lost to follow-up, 3 young patients who failed to retrain but are alive and well at the time when the paper was written. When one patient was adequately training but died of intercurrent illness, and 1 patient had a band and was operated in another institution and died because the reporting team believed that the double switch was done too early. Here you have on the left panel, you have freedom from death, transplantation, and moderate or severe left ventricular dysfunction. On the right panel, you have the patient who survived and the freedom from moderate or severe left ventricular dysfunction. So at some stage, 2 years, between 2 and 4 years after the double switch operation, you have 40% of the surviving cohort have moderate or severe left ventricular dysfunction. This is the current protocol in Birmingham until at least David Barron went to Toronto. I would like you to concentrate on the yellow group where the patient have failed to reach during the cath assessment the 80% of the systemic pressure, and an ASD is created. The ASD is created in the goal of increasing the volume loading of the left ventricle and increase the training further. We have a reverse experience in patients who are being trained and have an ASD. Actually, when the ventricle train, the compliance become less and the VSD shunts right to left, so blue to red, and you have desaturation that appears and the volume loading of the left ventricle decreases. And we actually continue training this patient, 1 patient, and we continue training that patient by closing the ASD, and the patient eventually had a double switch and went well. In Boston, you have the same very aggressive banding strategy, and they are even more restrictive. The limitation in terms of age for banding and age for double switch is 2 and 3 years of age, respectively. So even more restrictive than what the people in Birmingham or Roger Mee would claim. The approach from Stanford is quite original. They have designed the retraining ratio. Retraining ratio is the ratio between the gradient that you should achieve to train the ventricle and the gradient that you actually achieve in the operating room. When this ratio is close to 1, you have a very high probability of actually positively retraining and doing the double switch. The threshold is 0.31. If you are beyond 0.31 with that retraining ratio, you will never train. But 0.31 is quite easy to achieve. On the other hand, they do not find any influence of the age, and they claim that you can train, and we believe the same, that you can train all the patients. So I present 2 series at the Children's Hospital, the historical series, so that all the patients that have had banding, that is almost 40 patients, and it include D and L-TGA. And you see the decreasing probability of successful retraining with increasing age at the pulmonary artery banding. This is significant. This age 6, 7, 10, or 12, and above 15. But and when you analyze the patient in detail, you can it's not as significant as what you think. The first patient was banded in 1977. And it was banded very aggressively. Eventually, the band was eroding, and the pulmonary artery banding and the training was abandoned. So this is a patient that is included into the statistics. You have another patient, but I banded at 18 years old, who was banded. We banded him with very severe right ventricular failure, which continued to decline, and eventually was put on the transplant list quite rapidly, and but died on the waiting list. The other patient, one patient is interesting, is a patient who had a pulmonary artery band in infancy, and then, in infancy, he was banded at 7 years of age, but in infancy, he had a suprasystemic left ventricular pressure because of subpulmonary stenosis. The subpulmonary stenosis was resected in another unit, and that created an AV block. So the left ventricle was detrained, and at 7 years of age, we trained him again. And so eventually, he had a double switch when his left ventricle was not trained enough. So we continued the retraining with an ECMO, and eventually, after biventricular pacing, the patient has a decent ventricular function and is doing well. These are patients corrected transposition who received a double switch operation. Significantly, there is a difference between the age at pulmonary artery banding. But again, you find when you study the patient carefully, you find that there is telling the story makes the statistics not as significant as what you think it is. It's not as clear-cut. So currently, the strategy we have is to band early in the history of right ventricular failure, or in the when there is tricuspid regurgitation. We band loose, so the target is not 60, 80%, but the target is 50%. Or if you have a high LV to RV pressure ratio to start with, you increase, you have a gradient of 30 millimeter of mercury. You reband when it is necessary, but you don't reband 2 weeks or 1 week after the first band. You reband 6 months or a year afterwards. It is very important to use the growth of the patient, to allow the patient to grow into the band, and that allows the patient to have a very progressive retraining. And I believe very strongly in the role of puberty. There are some studies, controversial, that suggest that there is actual hyperplasia in the heart and the left ventricle at the time of puberty, so multiplication of the cardiomyocytes numbers. And we want to use that effect, or at least we want to use the growth spurt that occurs during pulmonary artery band. So we try to have the patient banded before puberty and allows the patient to grow into his band over a period of 2 years or 3 years. So the current patients since 1996, 17 band. We have banded in 2017 and 18 4 patients. 2 are ready. They were less than 3 years old, and 2 are getting ready. They've been banded before puberty. 2 palliation was in an adult that was trained, but the right ventricular function actually regained, improved significantly, and the patient is now transitioned into the adult care, but is doing very well, and so we don't, he's choosing not to have a double switch. And a patient was trained in 2009. Then the parents moved to New Zealand, and the left ventricular function declined a little bit, and then the patient has been debanded, loosely debanded. 1 patient died. That is the patient that I've told you about. And we had done 10 switches, 1 CV dysfunction, 1 moderate, but the patient should improve with the placement of a resynchronization device, and 1 has a mild dysfunction that I told you about. There are experimental data that suggest that you can have a much more efficient and much more deleterious way of training the ventricle by applying a intermittent pressure gradient. So it can be either using a balloon into the pulmonary artery, as was described by Philippe Bonhoeffer, and you can inflate that balloon an hour or 2 hours per day, and you find that the retraining is much more efficient, faster, and without an increase of the collagen load of the ventricle. And then there is a similar experience where you trained, I think it is, I can't remember what is the sequence, but it is also an alternative. And you see as well a decline or an absence of increase in the collagen load of the ventricle. Another part that is important in the double switch operation is the senning. You know that the senning operation is in a DTGA. It's a limiting factor in terms of exercise capacity because the compliance chambers, the atrial chambers, are very small and not very distendable. So the exercise ability is limited by the amount of blood that can reach the right ventricle. So in order to increase that, you have to use enlargement of the chambers with patches. And we also have had, in our experience, we have had a certain number of reoperation because of obstruction of the pulmonary venous channel. So we optimize that operation using the Schumacher operation, a Schumacher modification. Schumacher modification is the enlargement of the systemic venous channel, of the pulmonary venous channel. So here you have the pulmonary vein, you have the mitral valve is here, and this is the systemic venous channel, and you use, in the normal Schumacher modification, you use a patch to increase the size of that channel. In the modified modification, we use the autologous pericardium in situ, so vascularized. And that gives you very big pulmonary venous channel in red and systemic venous channel in blue. You can see on a situs, on the left panel, you see in a situs solitus a bulge of the pulmonary venous channel that has been augmented, and in a situs inversus, you also see the bulge of the pulmonary venous channel being augmented. And this is a dynamic, and you see the very large chambers and the absence of obstruction. Very important is the aortic valve or neo-aortic valve. Every team report an incidence of significant or severe aortic regurgitation immediately or at some distance from the double switch, and that generates morbidity, mortality, and has an incidence on the ventricular function. So the aortic valve is damaged by the band when the band is too close to the free edges of the pulmonary valve. And there is also, if you induce a very severe gradient on a valve that is used to work at low pressure, you induce a dilation of the sinotubular junction that will eventually be fixed at that level. So the prevention of that phenomenon is to move the band away from the free edge, so as close as possible without interfering with the pulmonary artery bifurcation, fixing it there well, and also try to avoid very severe gradient to avoid the dilation of the aortic root. So you also need, during the double switch, to have a low threshold for an aortic valve replacement. But there is also an alternative. When you do have a damage to the pulmonary valve, you can do a Beck-Snicaido and a double translocation. These patients are very appropriate for double translocation. We have in our experience 6 Beck-Snicaido and Stenning, and including 2 double translocation. We have the aim of doing more because it's a very, very good operation. In patients that have unrestricted VSD, the strategy we have is to do the double switch when the patient needs it and not protect the pulmonary circulation with a band. So you can do the double switch in infancy at 4 months, 5 months of age, or even earlier if you need them. So I would like to report an experience that is, I think, very important, the pulmonary valve and subpulmonary stenosis. This patient with a severe subpulmonary stenosis and a normal pulmonary valve, they have the setup, the anatomical setup for a double switch. You resect the subaortic subpulmonary stenosis, and you have a left ventricular outflow tract that is free of narrowing, and you can do a double switch. On the other hand, because most of the time this patient have a very severe pulmonary stenosis, the pulmonary valve and the pulmonary root is extremely flimsy, very light in collagen content and elastic content. And when you do a double switch in that setup, the pulmonary root or the neo-aortic will dilate very significantly. I say that because we have lost a patient that developed severe aortic regurgitation 6 to 8 weeks after the double switch. And we have encountered another patient recently that had the same very flimsy pulmonary root, and we did a double root translocation, and the patient is doing very well. Conduction anomalies are very important. They're very important because the interaction between pacing and ventricular function is extremely important. So here it's trying to explain to you what are the difficulties, what are the anatomical setup for the abnormal conduction tissue. Just a reminder, the incidence of complete AV block in corrected transposition is 1 to 2%. So out of 100 patients with corrected transposition, 1 or 2% will have an AV block every year. So here you have you can see that the interatrial septum and the interventricular septum are completely are they're not in alignment. So you have the posterior node here has no connection with the septum, and the only way to have a connection to the septum is to have the anterior node and going around the pulmonary route. On the other hand, when there is a pulmonary atresia or severe pulmonary stenosis, you have an alignment and the posterior node can connect. I think I said it right, but I'm not sure. But what is important is that the resynchronization therapy has to be used. It is demonstrated by all the team, and it has to be used every time the patient needs pacing. So every time the patient is compatible, you have to use it when you train. If there is an AV block at the time of the training, you have to use it if there is an AV block that appears during the training period. You have to use it during the double switch when there is an AV block at that stage, and when the AV block is iatrogenic. And when a patient has had a double switch and is on a DDE pacing system, you have to convert it to a resynchronization therapy. It is important, the placement of the electrodes is very important. You have to place the left ventricular electrode at the base of the left ventricle. So you have the left ventricle is here. You have to put them really at the base. And this right ventricular apex is here. That's where you pace. You can see that this patient had initially a DDD pacing system, and you still have the previous electrodes. So the closing remarks, avoid bending when possible. You have to bend early, bend loose, and delay before rebend. You have to be patient, so allow for several years, 3 years, 4 years, 5 years to train the patient, and use the growth of the patient to allow the patient grow into the band, especially with the growth spurts of puberty, so bend before puberty. You have to aggressively seek neo-aortic competence, so protect the neo-aortic valve during bending, and have alternative strategy when there is a hint of damage to the aortic valve. Use resynchronization therapy liberally with attention to the placement of the leads. And beyond puberty, failure to achieve left ventricle training is not necessarily bad for the patient. You will note that a lot of these patients that have failure to train are still alive, and some of them are doing very well.